Hello, I'm Eric Garcia. I'm a nurse practitioner student at UTEP in the Adult Geriatric Acute Care Nurse Practitioner program. This is my webcam presentation for Acute and Critical Illness 2. This is a patient I came across during clinical rotations at my hospital, and he was positive for COVID. I followed him for about 2 weeks actually, and he ended up declining, and family placed him on hospice, and he did pass away in the end. But let me go over the rubric. We'll go over each detail. So because I saw him so long, we'll start with like the beginning, and then I'll go ahead and do more of the review of systems physical exam with the more recent findings. So presentation of HPI. He resided in a SNF here in El Paso as he had some comorbid conditions. At the SNF, he started having some shortness of breath, some fever, a little bit of anxiety. So they went ahead and tested him for COVID. Turned out he was positive. He got transferred to my hospital to continue to receive care there. Past medical history does include end-stage renal disease on hemodialysis, hypertension, hyperlipidemia, bipolar disorder, Parkinson's disease, seizure disorder, obesity, and metabolic syndrome. Past surgical history does include a tonsillectomy back in the 90s per family, uvuloplasty, AV fistula placement, resection of his prostate in 2017, followed by a cystoscopy with TERP also in 2017. He did have a fall where he underwent a closed risk reduction in August of 2017 as well. Social history, he does drink socially, very little, 1 or 2 beers. He denies any smoking, never smoker. He denies any illicit drug use. Family history is positive for premature coronary artery disease, cancer, stroke, and first-degree relatives, as well as hypertension and diabetes. Okay, so speeding things up. Initially, his review of systems was basically unremarkable. A little bit of shortness of breath, maybe some wheezing. He didn't feel too bad, bouts of anxiety, but as time progressed, review of systems became difficult to obtain. And he was difficult to arouse, only to nauseous stimuli, difficult to talk to. So towards the end, he was declining prior to being placed on hospice, where he wouldn't vocalize much, maybe 1-2 words, mostly no, and let you know if he was in pain. Physical exam, because he was on the COVID unit, I was minimizing my exposure. I would speak to the nurse, and we did have telemonitoring, so I can speak to him if needed. But as I said, towards the end, he was getting very difficult. But in his last few days, he didn't appear in any acute distress, non-toxic appearing. Lungs per bedside RN was diminished bilaterally. She couldn't hear any wheezes, rales, or rhonchi. Stated everything was symmetric. No issues with his head or neck. Heart was regular rate and rhythm. Although, again, in his last 48 to 72 hours, his rhythm did start to widen. He became tachycardic prior to that. But for the most part, for the first almost 2 weeks there in the hospital, rhythm was unremarkable. No edema, peripheral pulses were normal. No issues with the abdomen or GI. GU, he was anuric, receiving the hemodialysis. No lymphadenopathy noted. Extremities were normal range of motion. He had equal strength and everything up until he passed. Skin, no rashes or lesions. He did have some redness going on due to the high flow around his I guess cheeks and nostril area. We had placed padding and protective barriers, but that's limited. Neuro-wise, let's say 3 days prior to him passing, the day prior to placing him on hospice, he was only awake and oriented to himself. I'd say GCS of about a 10 or 11. He would localize to nauseous stimuli and answer yes and no, but that's about as good as we can get. He was aware of himself, but not situation or place, time, anything like that. Assessment. This one had quite a bit of things that continued to develop. So again, prior to placing patient on hospice, positive for COVID-19 bilateral pneumonia. That's the main thing. Also pulmonary congestion, fluid overload due to lack of hemodialysis prior to this, which has been corrected. We were almost doing hemodialysis daily, but I'll get to that in the plan. Severe hyperkalemia, end-stage renal disease on hemodialysis, hypertension, hyperlipidemia, Parkinson's disease, seizure disorder, morbid obesity, and obstructive sleep apnea, thrombocytopenia, tachycardia, and also a poor prognosis. Plan. We will continue with the airborne precautions and isolation for COVID-19. Infectious disease consult was managing as well. IV antibiotics. We also did IL-6 inhibitor. I might be pronouncing this wrong. Tocilizumab. It is also used in treatment for rheumatoid arthritis. It alters killer T cell activation with these infections. So I know we get a lot of press coverage on hydroxychloroquine or chloroquine. That alters RNA synthesis in hopes of mitigating the COVID response on lung cells. This does similar things, but with the T cell when they attack it, once the cell is infected with the virus, to prevent it from rupturing and releasing its copies. So this will lessen that, the IL-6 inhibitor. We will continue to follow daily labs. Supplemental O2 and titrate has tolerated to keep SpO2 above 92%. We will continue to trend inflammatory markers, including a D-dimer as well, procalcitonin as well. Continue to monitor electrolytes, nephrology consult managing, and we will continue to follow the recommendations. Patient is receiving almost daily dialysis as tolerated. Continue with cefepime, per infectious disease. Patient is on dexamethasone as well for the COVID-19 pneumonia. Vancomycin has been discontinued. PT evaluation, but at this point, patient will not tolerate. Patient did become tachycardic. We added metoprolol, 5 milligrams every 6 hours as needed for the tachycardia. DVT and GI prophylaxis was done using heparin as well as Pepsid. Family was contacted almost daily for the progression of their loved one, and we gave him 2 weeks when that second week started. I was very frank with them, let them know this is usually when we see patients either make a turn for the better or the worse. We gave him that week. He continued to decline. I did a couple FaceTimes with them to try to talk to him. Towards the end, he wouldn't wake up for them. So with the family all coming together, making a group decision, they decided to place patient on hospice, and we went ahead and discontinued all those treatment modalities and just focused on comfort care and keeping the patient comfortable. He did end up passing in about 2 days after hospice was established. And that's it for my case presentation. Number 1. Thank you, and hope you enjoy.